introduce our third presentation in this series between Extend Pharmacy and Whole Health Pharmacy Partners. Megan, we're very happy to have you joining us tonight. I know that I've reviewed the slides and there's a lot of great learning opportunities in here for community pharmacists. So thank you for joining us. To introduce Megan, Megan Hayes is the pharmacy manager at Extend Pharmacy, which is an oncology specialty pharmacy located in Ottawa. It opened in November 2019. So just 2 years old. Happy birthday, Extend, for your 2-year anniversary. So Megan completed her Bachelor of Science in Pharmacy at Dalhousie University in 2012, and then went on to complete her residency at the Ottawa Hospital in 2013. She recently completed her post-bac PharmD at the University of Toronto. She has a diverse background in pharmacy, including working as a clinical pharmacist and a drug information pharmacist at the Ottawa Hospital. She's a clinical pharmacist at St. Vincent Hospital and Elizabeth Bruyere Hospital, as well as part-time community pharmacist and an injection certification instructor. Megan is also experienced with research and has authored several publications. Megan has since delved into the world of outpatient oncology, where she has been focusing on educating patients on managing side effects related to oral cytotoxic and targeted therapies. Megan strives to ensure each patient receives optimal care and is supported throughout their treatment journey by the wonderful team at Extend Pharmacy, where she's the manager. So Megan, I'll let you introduce the topic and we'll move along. Thank you, Megan.
Thank you so much for that. So I'm very happy to be here tonight for the third part of this series. So tonight I wanted to talk about GCSF products and just get some background information on them and then present some practical management for community pharmacists who may encounter these products in their practice. So just for my disclosure slide, so just so you know, I have received speaker and consulting fees from a few pharmaceutical companies, so Novartis, Mylan, Pfizer, and Apo Biologics. Mainly to do with presenting on oral oncology products or GCSF products. So the objectives for the presentation this evening. So I'm hoping by the end of this session, you will be able to understand the role of the community pharmacist in supporting patients who are receiving GCSF products, recognize key differences among the GCSF products currently available on the Canadian market, confidently counsel patients and their caregivers regarding GCSF administration, monitor for and manage side effects associated with GCSF administration. And then also I wanted to get you to be able to troubleshoot some common issues that might arise during and after dispensing GCSF products. So here's our first polling question for this evening. So thought I'd start by getting everybody interactive. So how frequently do you dispense GCSF products in your practice? So daily, weekly, monthly, a few times per year? Getting a few answers coming in here.
Yeah, and Megan, I'll comment while we're waiting for folks to fill in the poll. If you have questions throughout the presentation, we're happy to take them. We might leave them till the end. So please feel free to put them into the question and answer feature on Zoom. So I'm going to end this poll, Megan, and share the results.
Perfect. So as you can see, so weekly, monthly is most common, and then a few times a year. And so that's pretty good breakdown. So no one's doing it daily. So interesting. That's great. So you are dispensing them. So that's good. All right. So I just wanted to start with a case. So Jenna, who's a 38-year-old female, presents at your pharmacy. She tells you she's undergoing treatment for breast cancer, and she's getting chemotherapy. She presents a prescription to you for supportive medications, and on that script includes a prescription for the following. So Filgrastum 300 micrograms subcutaneous daily for 7 days. So now another poll. So what information do you need to appropriately fill and counsel on this Filgrastum prescription? So do you need patient weight, what chemo regimen she's getting, the chemotherapy cycle length and start date, the brand name of the Filgrastum product, none of the above, or all of the above. And I'm going to get you guys to, we're going to come back to this question at the end. So if you change your answer at the end of it, that's okay. We'll discuss. That's great. Okay. So we've got some answers here. So we have the chemotherapy cycle and start date, 50%, so the brand name of the product, and then all of the above. So we'll definitely come back and talk about that as we go along. So just a background on G-CSF pharmacology. So G-CSF stands for granulocyte colony stimulating factor. And everyone's body has an endogenous production of G-CSF. So G-CSF is produced by monocytes, fibroblasts, and endothelial cells within your body. And what it does is it results in the proliferation, differentiation, and activation of progenitor cells that are in the neutrophil granulocyte lineage. And then it also, so it makes more neutrophils, and then it also enhances existing neutrophils' ability to attack bacteria. So it enhances phagocytosis, chemotaxis, and antibody-dependent cellular cytotoxicity of neutrophils that are already in circulation. So normally in the body, the endogenous G-CSF levels are actually undetectable in healthy adults. And interesting, so it may be detectable in those who are fighting an infection, which makes sense because they're going to want to ramp up neutrophil production, or if they're in stress conditions such as undergoing cytotoxic chemotherapy, because the neutrophils in the body may be decreasing. And so another kind of interesting point in G-CSF pharmacology is that usually once a G-CSF is administered, the neutrophil count in the bloodstream actually decreases for the first 24 hours due to something called marginalization. And then after that 24 hours, you start to see it increase. So something you wouldn't want to check neutrophils after 24 hours after administering one of these products, because you would see a decrease. Filgrastum, so the short-acting G-CSF product that's available in Canada, increases neutrophil production about 9-fold. It also shortens the time that's required for neutrophil precursors to mature and appear in circulation. So without administering any G-CSF product, the process of the neutrophils to mature is 4 to 5 days. And then if you do administer a G-CSF product, it actually shortens that quite dramatically to only a 1-day process. So this is just kind of a summary of that. So what happens with G-CSF when it's given. So you get an increase in G-CSF blood concentrations, and what that does is it causes granulopoiesis. So we get accelerated mitosis in the bone marrow. We get more neutrophils that are being produced. We get that shortening of the process time, and what that does is it results in an increase in circulating neutrophils. And then at the same time, we get on the left-hand side of your diagram, mobilization and demarginalization. So any of the neutrophils that are kind of stuck on the blood vessel walls will get pulled into the circulation, and if they're in different areas as well, they'll be mobilized into the bloodstream to help fight those infections. So when patients are using G-CSFs when they're undergoing chemotherapy, what they're doing is they're using the G-CSFs to decrease the risk of febrile neutropenia. And the definition of febrile neutropenia is an absolute neutrophil count, so an ANC count of less than 1,000 millimeters cubed, which you'll also sometimes see reported as less than 1.0 times 10 to the 9 per liter neutrophils. And then also in combination with that, a single temperature reading of at least 38.3 degrees Celsius, or a temperature reading of 38 degrees Celsius sustained for at least 1 hour. So you'd need at least 2 different readings on that count to see if it was sustained for over an hour. And if the patient has both of those, they meet the criteria for febrile neutropenia. And so what is important about febrile neutropenia is kind of the impacts on the patient. So febrile neutropenia is associated with poor patient outcomes. So these include decreased total chemotherapy dose and a decrease or delayed chemotherapy treatment schedule. And what that can do is, especially if the chemo is for a curative intent, that can cause, poor patient prognostic, so the therapy is not as effective. Patients can also get hospitalized or prolonged hospitalization if they get febrile neutropenia, and they can also be exposed to a number of broad spectrum antimicrobials. So if you've ever had a patient who's been admitted to the hospital, most hospitals have protocols for a patient who comes in if they do have meet the criteria for febrile neutropenia, so that ANC of less than 1, and then the fever. Oftentimes what they do is they'll administer these broad spectrum antibiotics, and usually it's more than 1 right away while they're working up the patient. So that can come with all of the negative effects that are associated with broad spectrum antimicrobial exposure. And just to kind of put this in numbers, so this is from the Cancer Care Ontario GCSF guidelines and their recommendations from use. It's a little bit older, it's from 2016, but still impactful. So in 2014, 42 and 45% of patients receiving adjuvant chemotherapy for breast or colon cancer had unplanned visits to the emergency department. And of these visits, neutropenia, fever, or infection were the most common causes. So 43% of those unplanned visits in breast cancer patients were due to neutropenia, fever, infection, and 23% of those unplanned visits in colon cancer patients were due to neutropenia, fever, and infection. So quite a significant impact on patients undergoing chemotherapy and causing them to have unplanned hospitalizations and unplanned hospital visits. And so how patients are categorized if they receive G-CSF products is what the risk is of febrile neutropenia for their specific chemotherapy regimen. So chemotherapy regimens are characterized based on that risk. So there's a high risk of febrile neutropenia, and that's considered a regimen that has a risk of at least 20% of patients getting febrile neutropenia without getting exposure to G-CSF products. There's moderate risk regimens, which are 10 to 20% risk, and then low risk regimens, which are less than 10%. So when using G-CSF for primary prophylaxis, and primary prophylaxis would be a patient going in to receive chemotherapy for the first time without having had previous cycles, getting a prescription for a G-CSF product to be administered right after their first round of chemo. So that would be indicated in patients who have a high risk of febrile neutropenia, so greater than or 20% with that regimen, or if they have a regimen that has a moderate risk, so that 10 to 20%, but they also have additional risk factors. So there's quite a long list of additional risk factors, but these are the ones that have the highest evidence associated with them. So if they have a 85% or greater relative intensity of their chemo regimen, if they have a history of extensive prior chemotherapy or radiation to the bone marrow, because that can result in the bone marrow, its ability to create neutrophils is diminished. If they're older, so if their age is over 65, or if they have a high burden of tumor within the bone marrow, that can also significantly impact their risk of developing febrile neutropenia. So that would kind of bump them up to that high risk category, and then they would be eligible for the G-CSF for primary prophylaxis. If you're wondering, so you can look up the risk of febrile neutropenia from the individual chemotherapy regimen. So if one of your patients did know what regimen of chemotherapy they were getting, they could quite easily, you can quite easily look it up in those G-CSF Cancer Care Ontario guidelines. This is table 2, so it's at the end of the document, and it shows you the risk of high, low, or moderate, and then you would take into consideration their risk factors if you were wondering if they met the criteria for primary prophylaxis. And I will mention right here that in Ontario, if you're practicing in Ontario, this isn't something that's a huge consideration for you, because we are lucky in the sense that Ontario Drug Benefit Program it's an open or general benefit on the formulary for Filgrastim and Filgrastum, whereas other provinces across the country, it's not. So it's restricted. So it's either exceptional access or some kind of LU code, and oftentimes it's associated with like whether or not the regimen actually meets the criteria of being high risk, and whether or not the regimen is for a curative intent. So when using G-CSF products for secondary prophylaxis, the recommendations are as follows. So it can be, so Cancer Care Ontario recommends G-CSF can be considered if further infections in the next treatment cycle would be considered life-threatening, if a dose reduction would bring the dose below the effective studied threshold, or if a lack of protocol adherence compromises cure rates or overall survival. The American recommendations or the ASCO recommendations are quite similar. So it's if a patient experiences a neutropenic complication from a previous chemotherapy cycle where they didn't get primary prophylaxis, if that reduced dose intensity might compromise their treatment outcomes. And then the ESMO guidelines, which are the European guidelines, are very similar as well. So they say it would be indicated secondary prophylaxis if a dose reduction below threshold or a delay in chemotherapy is not desirable. So again, it's often tied to chemotherapy with curative intent. But in Ontario, we're lucky because we don't have to meet these criteria in order to get it covered for patients. With private insurance plan, sometimes it's a little bit more tricky, and they do have specific criteria that they need to meet, and some of them still use older criteria, but if the patient does at all have home care or has any kind of access to ODB, it's a general benefit. So poll question number 3, so we've been talking about neutrophils a lot, so when are the neutrophils the lowest during myelosuppressive chemotherapy? So after receiving it, when are your neutrophils the lowest? And so is it 24 to 72 hours after chemo, 12 hours after chemo, 3 to 5 days, 7 to 14 days, or you can also answer, I don't know, that's why I'm attending this presentation, I have no idea. So do any of you guys know? Okay, that's great. So yeah, that's awesome.
Thanks for getting some answers here. So everybody feel free to, don't be shy.
Yeah, don't be shy.
Learn.
Perfect. It's awesome. Because I'm talking all about this neutrophils, and it's probably a good thing to know when they're going to be at the lowest. So that's good. So a lot of you said 24 to 72 hours after chemo, and then I don't know, which is great. So we'll go on to that next. So neutrophils are generally actually at their lowest. We call it the nadir. So the lowest point, actually, it's usually between 7 and 14 days after receiving the chemotherapy. So you can see here, the chemotherapy was administered, and then in this case, this is from the Neupogen website, so it would be Grastafil or Filgrastum, like the product was administered, and then the neutropenia occurs looks like around day 12. Here's the nadir, but anywhere from 7 to 14 days. Interestingly, so once the Filgrastum, the short-acting G-CSF product, was administered, you can see quite nicely on this graph what it's actually doing to the neutrophils. So it is, first of all, you notice that they don't go down as low, which is great. The nadir occurs a little bit earlier than before, and then they recover quite a bit quicker, and they get quite a bit higher, quite a bit faster. So that's going to offer the protection to patients because their immune system is going to be better functioning at that point, and they're in that really low, like below 0.5 for significantly less time. And so just to discuss kind of what products are available in Canada. So I've been mentioning them, but there's Filgrastum, which is the short-acting G-CSF product. It's the very first product that was available here. Neupogen is the originator drug made by Amgen. And there are biosimilars available now on the market. So there's 2 biosimilars. So there is Grastafil, which is manufactured by Ava Biologics, and then Nivestim, which is manufactured by Pfizer. And then Pegfilgrastim is the originator drug was Neulasta, which was made by Amgen. And then there are even more biosimilars for Lepelgo, which is interesting. So for Neulasta. So there's Lapelga, which is Biologics. There's Flafila, which is Mylan, Nivipria, which is Pfizer, and then the Zextenzo, which is Sandoz. And each of these different products do have patient support programs that are associated with them as well, in case patients can't get funding or if they have co-pays associated with them. So that's good to know. And I just wanted to highlight some of the differences between the products. So the Filgrastum versus the Filgrastum. So Filgrastum was like I mentioned, the first product. So it actually has more indications for use than Filgrastum does. So its first indication, so is the myelosuppressive chemo, which is what we're talking about. It can also be used in hematology patients, so patients with acute myeloid leukemia, those who are getting myeloablative chemo and getting a bone marrow transplant, and then getting collections and therapy. It can also be used, it's also indicated by Health Canada for use in severe chronic neutropenia. So this can apply to any patient, so they're not having chemo, they just have a chronic neutropenia for whatever reason, they can be using that product. It's also indicated for patients with HIV infections. Filgrastum, which came on the market later, only has one indication, and it's only indicated for patients receiving myelosuppressive chemotherapy. So normally if you see a script for Filgrastum, it would be for that indication, whereas Filgrastum, they might not be getting chemo, there might be some other reasons. The dosing is different between the two products as well. So the dosing is 5 micrograms per kilogram subcutaneously daily for up to 2 weeks for Filgrastum. So it's weight-based dosing, and it's usually, I said 7 to 10 days, it can be 5 to 10 days. And the half-life is actually quite short for Filgrastum, so it's only about 3.5 hours. So that's why it needs to be injected daily. And once you kind of withdraw, like you take away the treatment, neutrophil levels tend to start tanking again in 24 hours, and they go back to their baseline levels in about 1 to 7 days. With Filgrastum, it's a fixed dosing, so that's nice. It's 6 milligram subcutaneous in a single dose. And the only thing with it is that you can't administer it in intervals that are shorter than 2 weeks. So depending on the patient's chemotherapy regimen, they may not be eligible to use Filgrastum, because if their cycles are too close together, they have to use a short-acting. The half-life for Filgrastum is substantially longer, so it's 25 to 49 hours. So what would happen is if a patient is getting a chemotherapy regimen and they get a script for Filgrastum, they'd only get 1 single injection, as opposed to the Filgrastum where they'd be getting multiple injections. And so just a note of the different products that are available in Canada that I mentioned before. All of the products are preservative-free, so that's an important point, and all of them must be refrigerated, so between 2 and 8 degrees Celsius. They all come in prefilled syringes, but Neupogen brand and Nivestim brand of the Filgrastum also are available in vials. Normally, you would see most prescriptions written for prefilled syringes, but if it was for like a pediatric patient, it might be in a vial, and there's some other, if they had a funny dose that needed a little bit of titration, you might see them prescribing a vial. The other thing is, so the Nivestim and Nivipria, which are the Pfizer biosimilar brands, they're the only ones that state that they're latex-free. So if you did have a patient in the community that had a latex allergy, those are kind of the ones that you'd want to choose. Although the latex that are in the other products are actually really only in the cap of the needle, so they don't actually touch anything. It's just that needle cap might have latex or natural rubber. And then another good thing to note is that all of the products are stable for at least 72 hours at room temperature. Some of them are actually stable all the way up to 15 days. So usually I'd say just check the product monographs, because they actually are really good and they have that information in them if the patient leaves it out. But there is differences about the available data for the stability at room temperature between the products. And just a note here, all of the biosimilars are not interchangeable. So unfortunately, a script needs to specify which biosimilar brand to dispense. So if it doesn't state it, theoretically you need to get that clarified, which is a pain, I know. Most of the scripts that come from the hospitals will have the brand name indicated on it. So if they generate it through Epic or whatnot, it usually picks a brand for you. If it's not there, you do need to clarify with the prescriber, but that's an issue because it can cause treatment delays for the patient. And you know, and like if you have something different in stock or whatnot, it can be a big issue. And I'm just going to quickly go over the administration overview, and this is just kind of so you can help guide your patients through it, or if you're helping them to do the first injection, you kind of know what to look out for. So for the timing of administration, so both pegfilgrastim and filgrastim need to be administered at least 24 hours after the end of chemotherapy. So not within the first 24 hours. And so if you administer the pegfilgrastim and filgrastim within the first 24 hours, the thought is that so the chemotherapy that's just been administered is targeting rapidly dividing cells. So if you get rapidly dividing cells and you're giving pegfilgrastim or filgrastim, that's stimulating the bone marrow to rapidly divide, so the chemotherapy could inhibit the pegfilgrastim and filgrastim from working. And then 24 to 72 hours is the optimal administration time for administering pegfilgrastim and filgrastim. And the reason for that is there's data that's been collected. So most of the guidelines state that 24 to 72 hours is the optimal window. And there was a study done in 2019 where they looked at same-day administration of G-CSF products, guideline administration, so 24 to 72 hours. And then they also looked at late administration, so greater than 72 hours. And what they found is that in reality, the ones that were administered on the same day and the ones that were administered up to 72 hours had a much better effect and prevented febrile neutropenia better than those that were administered after that 72-hour mark. So we always want to kind of make sure that the patient's best protected by getting in that window. So just administration setup. So what I like to have set up when patients come in, so the alcohol swabs, I like to have a cotton ball available in case there's any drips that come off the syringe when you actually do the injection, and then just their sharps container available. So this is what the prefilled syringes look like. I don't know if you may have played with them or not before, or helped a patient to do the injection, but they're really actually quite nice. So I think this one is from the Graceful monograph, but I think they all look very similar. They're nice prefilled syringes. There's a plunger. There's needle guard activation clips. So those are just once you get down to the end of the syringe, you need to press the plunger all the way. Those needle guards actually click, and then the syringe retracts. The needle retracts back into the body of the syringe, so it's like a safety mechanism for the patients. I just like to note that because it can be quite alarming for you if you're doing the injection the first time when it happens, because it clicks pretty loudly, and it makes a little shock in your hand. And sometimes when patients are doing it, they're like, "Oh, did I make a mistake, or did I do something wrong when I was administering that?" Because of how it feels in the hand. But no, that's totally normal. And then just really important practical points. So the syringe should really be at room temperature prior to the administration. So you should leave it out for at least 30 minutes before injecting. So if you're going to give the injection and you know the patient's coming in at a certain time, just remember to take it out of the fridge before they get there, because it should come to room temperature on its own without like you heating it in your hand or anything like that. And then patients as well, they should take it out beforehand. Like I said, they're pretty stable at room temperature, so if you take it out like an hour before, that's fine as well. And another thing is don't shake it, because if you do end up shaking the syringe at all, it can result in foaming of the solution, and you don't want to inject like that kind of foamy solution because it won't inject properly for the patient. For the administration location, so it's any of the regular subcutaneous areas. So around the navel is probably the easiest and usually the one that I use the most. They can also do it in their thighs as well. Back of the arms if someone else is administering it for them, because it's a bit hard to do that yourself. And also the area just on the lower back hip area as well. But honestly, in all honesty, I usually just stick with the navel region. And then for the technique, it's just a regular subcutaneous technique. You want to make sure it's at a 45-degree angle. You can do up to a 90-degree angle depending on if the patient is large or not large, but 45 is usually works for most people. And then when you're doing the injection, sometimes there's a bit of burning and stinging for the patient when doing it, usually not too much, and it's usually better if the syringe is at room temperature. And then just to note again that the needle does retract back into the syringe once you depress the plunger all the way. So you're not able to hold the needle in place like you're technically supposed to, because it does shoot back into the syringe. So just, I wanted to go over now just some side effects and monitoring. So the most common side effects you're going to see with the GCSF injections are injection site irritation. Usually it's minor, and it's usually only right when you're doing it, and it's usually a little bit of burning or stinging. If it's more than minor, if it's red or itchy like days later, that's not a normal side effect. Bone pain is another side effect that's probably the most common one. It's about 22% of patients that experience that. And it can be, some patients get mild bone pain and some patients get severe bone pain to the point where it wakes them up at night and they can't sleep and things. So it can be quite debilitating for patients, and it is a good thing that pharmacists can help monitor. The other thing that can happen in about 12% of patients is they can get a fever, which kind of presents a problem because then you're kind of stuck. What do? They're a fever, they're getting a chemotherapy regimen. So what I tell patients is like, for monitoring their temperature, only do so if they're not feeling well. Because if they just inject the G-CSF and then they otherwise feel fine and they check their temperature, they might have a fever. Rare but serious side effects, just to note. So splenomegaly or splenic rupture can happen to patients getting G-CSFs. Also, acute respiratory distress syndrome is a big one. Hypersensitivity reactions, and usually those occur in the first 15 to 30 minutes. Sickle cell crisis, and then a kidney injury is another one that can happen. So these are just things that you would want to monitor for if a patient called you for, things that you can kind of look out for, red flag issues, and when to kind of direct them to go to emerge. So in terms of bone pain, in terms of side effect management, as I mentioned, this is probably the most common side effect that we see. So the first line recommendations are to use acetaminophen or NSAIDs. Acetaminophen is usually what I would recommend first. The only issue with acetaminophen is if the patient's not feeling well and they do need to take their temperature for any reason, just make sure that you let them know to take their temperature before taking the acetaminophen, or they can be masking a fever and they might meet the criteria for febrile neutropenia and then not know. NSAIDs are also a good choice that you can use in patients. However, some chemotherapy regimens can really affect platelets and decrease platelets and things like that. So if there's any kind of bleeding risk associated with the patient, I usually don't recommend it. So Tylenol is usually the first line recommendation. And then second line options are so opioids, antihistamines, or a dose reduction of the G-CSF. So opioids, as we know, is not very, right now, there's like the opioid crisis going on. It's very popular to not want to prescribe opioids for good reasons. And also, so patients may get prescriptions for opioid for this pain. Oftentimes I find that the opioids don't help necessarily a lot with that type of pain as well. So antihistamines sometimes are a better option for patients, which is interesting and something that you might see or get a comment from a patient. So the thought with the antihistamines is that when the G-CSF products are administered, there's a histamine release within the bone marrow that can cause swelling, and that causes the bone pain that they're experiencing. So some centers or physicians will recommend an antihistamine an hour prior to administration of the G-CSF product. And then another option is, like I said, dose reduction. That's not as commonly seen. So it's usually you'd want to do the acetaminophen and then antihistamines and then plus or minus opioids. And just a note, this is just a counseling point. So if a patient is coming in and they, or they're on the phone with you and they're having any of these issues, so if they have a fever, so again, one reading of 38.3 or 101 Fahrenheit if they're measuring in Fahrenheit, or a sustained reading for an hour of 38 degrees Celsius, send them to emerge because that needs to happen for definition for febrile neutropenia. If they experience any irregular heartbeat, chest pain, shortness of breath, anything like that, that would be a referral. If you're giving them an injection in the pharmacy and they're dizzy or they don't feel well after the drug is administered, you can send them to emerge at that point. In Ontario, it's not required that first doses of G-CSFs are given in a monitored setting. Some provinces do monitor them just in case there's issues like that. If a patient notices, if they call you and they've got dark urine, brown urine, any decreased urine output, or they're noticing that they have peripheral edema, so their feet are swollen, that can just be a sign that there's that kidney injury is occurring. So you definitely want to send them in to get assessed for that. If they report any kind of belly pain or shoulder pain, it's usually pretty intense, and this could represent any like that splenic rupture or a sickle cell crisis. So again, referral for that. And then again, any signs of hypersensitivity reaction. So any of the rash, wheezing, hypotension, and usually that occurs within 30 minutes of exposure. So in terms of pharmacist monitoring, I think the best thing pharmacists can do when monitoring patients are doing follow-up calls, just if they pick their medication up, a week before they're supposed to inject it, just to do a follow-up call with them on the day that they're supposed to inject it, just to make sure that they understand how to inject it and they don't have any questions before they do it, because oftentimes when they're receiving information and counseling from a bunch of different people when they're at the hospital, they can get overwhelmed, and maybe the first time when they picked it up from you, they were feeling overwhelmed. So just doing that follow-up call and kind of reaching out to them to feel like they're supported can really be quite helpful. The other thing you can do is in your follow-up calls, if they've already given it to themselves, you can ask about injection site reactions, or you can ask if they have bone pain, because even though you mentioned it during your counseling, they might have forgotten and they're wondering if this is a normal side effect and what they can do. And you might be able to prevent them from, having to go to emerge unnecessarily. And then the other thing is you can assess for red flags. So you can ask them those questions. You can ask them if they have any of those side effects, or you'll know right away if they call and they say that they have any of those side effects, that those are ones that you want to send them to emerge right away for. And just some counseling tips. So just if they're getting the Filgrastum, so the short-acting injection, just ensure that the patient alternates injection administration sites. So if they're getting Filgrastum for 7 days, what you don't want them to do is administer the Filgrastum in the same spot every day, just like any other injection that they're doing, because they can get those little hard fat pockets under the skin, which we don't want. So what patients can do, and what I kind of suggest, is if they pick a spot on their belly, they can either go clockwise or counterclockwise, whichever they prefer, kind of down below the navel area. And if they can even draw themselves a picture and do a little X, like I've done it this day, and then on day 2, I'll do it over here, and they can move about an inch or 2 away from the area they did before. And then that way they'll make sure that they're not going in the same spot. It seems basic, but just something to let the patients know and help them keep track of something is quite helpful. And then the other thing is with those prefilled syringes, if you're doing the injection or if you're training the patient to do the injection, oftentimes there can be a little leak at the end because the needle does retract right away into the syringe quite quickly. So sometimes if there's a little drip of product, just make sure that they wipe it off with a cotton ball or a gauze right away. We've had some patients have some kind of skin reactions to the product just sitting on top of the skin. Because they didn't wipe it away. So just a note on that. And then I think the most important thing is just making sure that the patient and perhaps the caregiver, because some patients have caregivers that are coming with them that are the ones that are going to be doing the injections for them because the patient is uncomfortable doing it themselves. So just ensure they know exactly what they're doing, that they have everything they need, they have their sharps container, they have their cotton balls, they have their alcohol swabs, and they're ready to go when they need to do their injection. And then the other thing is try to hammer home when they're supposed to do their injection. So a lot of times you can get a script and the physician will write on it like 24 hours after the end of their chemo. And they might be getting different types of chemotherapy. So sometimes they'll specify like at the end of this part of the chemotherapy. So just make sure that they're very clear on when they're actually supposed to start the injection so they're not doing it at the wrong time, and so that they're getting kind of the most amount of benefit possible. So back to the case that we were talking about with Jenna at the beginning. So what information do you think now, what information do you think you need to collect? So the patient weight, the chemo regimen, the chemo cycle length and start date, the brand name, none of the above, all of the above. Is it same, is it different? Have you changed your opinion?
So Megan, while we have you on this slide and people are answering the poll, I'll ask you a question. So do you think that a pharmacist in a community pharmacy, when they receive one of these prescriptions, should we be looking into which chemo regimen the patient is receiving to make sure that the medication is appropriate?
Yeah, so that's a really good question. So I think yes. I know sometimes it's really busy and it's hard. That's hard to do, but I think it is good to find out at least a background from the patient. Some patients, they might not know exactly what regimen they're on, but they might say like, oh, I go in and I get an IV and then I get a little infuser thing, a little baby bottle infuser that comes home with me, and that kind of gives you clues as to what the regimen could be. But I think finding out what the regimen is can be quite helpful, because that can allow you to know if it is appropriate for them to be getting it, or if there's a specific reason that they might need a little bit more support as well, like if they've had a history of neutropenia in the past and things like that. So it looks similar. So all of the above and then brand name are the answers. And like, I think that everyone here is right. So I think you really need the brand name according to OCP to dispense the medication, but I think getting the rest of the information makes everything the most appropriate that you can do. So checking the patient's weight is good. Just make sure the dose seems appropriate. Like I said, usually it's 300 milligrams, but micrograms, but you might have a patient with a different weight, so it's good to check. Chemotherapy regimen, the cycle length and start date, I think those are good to have because you can check and see if it's appropriate. And then also when they're supposed to be starting based on kind of the regimen that they're getting. And then the other thing is you can know if you are going to do follow-up calls with them, if you want to call them before their next cycle to see how things went, you kind of know when to time those follow-up calls as well. So that's great. And then this last little bit is just kind of troubleshooting, like things that might come up, and probably things we covered in the presentation already, but just kind of hammer them home. So if the patient calls you and they're in a panic and they say, I accidentally left my injection in the cupboard instead of the refrigerator because I came home and I was carrying groceries and I dropped them everywhere. Oh my God, what do I do? Help. So I think we already covered this, but they're quite stable at room temperature, which is very lovely. So if the patient left it in the cupboard and let's say it's the Grastafil brand and you've checked in the product monograph, it's stable for 15 days at room temperature. As long as it didn't go above 30 degrees Celsius, you're good. So just find out how long it's been out and kind of what temperature their house is. But oftentimes you'll get those panic calls. So if you do get those, that's okay. The patient is good to go. And then if they have other syringes, let's say they picked up 5 syringes, just get them to like mark it on the box, like how long they were out. So there's the exposure is actually cumulative. So once they put them back in the fridge, it kind of resets. We just have to keep that in mind. Another thing that might happen that could be very common is, oh my God, I forgot to order my injection and I'm supposed to take it today because my chemo started yesterday. Is it okay for me to start a bit late? So as we mentioned, if the patient, most of the time the directions that they'll get are to start about 24 hours after the chemo. So as long as they're in that window of 24 to 72 hours, that's okay. They can do it. So if there is a little bit of a delay, that's fine. Sometimes you'll have patients who, if you're helping them to do their injection or if they're coming in to do their injection, they might end, their chemo might end at a time where 24 hours later your pharmacy is not open. So if they can do it like the following morning, that is totally fine. Another one you might get that hopefully after this presentation you'll be comfortable with is, if my friend told me to take Claritin for bone pain, is this okay? Will it help me? I know the first time I heard that, I was like, what? Claritin for pain? What is happening? So just knowing kind of the rationale behind that, and that the evidence for it is not super good, but also if a patient there are some patients that find it helpful, and some of the evidence suggests it could be helpful, and really the side effects of taking Claritin or any of the antihistamines are not necessarily bad. So probably better than taking opioids in most cases. I've had patients who, like, one dose of Claritin doesn't work and they have to take it for a few days before their injections, and that has worked. So it kind of differs between the different patients. Another one you might get is if you're doing a follow-up call or if the patient calls, it says the injection site that I did my shot in yesterday, it's red and it's itchy. Is this normal? What should I do? This is, again, so red and itchy, not really a normal side effect of getting the injection. They might have a little bit of irritation in the area, a little bit of stinging, and maybe a touch of redness depending on the patient. But if it's really itchy and red, it could be a sign of an infection. So oftentimes they might get a fungal infection because they're, like, again, their immune system is not very good. So definitely would want to refer them for that. And then this one is the last one that I kind of threw in. When should I get my flu shot? Can I just get it at the same time as my Filgrastum injection? So I just kind of wanted to throw this one in case you get this question, given the time of year that we're in. So theoretically, so the Filgrastum would probably be given 24 hours after their chemo. And then really we want to give the flu shots as close to their next chemo cycle as possible. So technically, you shouldn't be giving them on the same day because the depending on what their chemo cycle is, it's probably kind of past the point where you should be giving them the flu shot and you should wait a few more days. The other thing with that is that sometimes the flu shot and they might get a reaction from the flu shot that is, like, they might look like they're having a fever. So sometimes that can be a confounding factor as well. And it might be in that timing when you're getting, like, their neutrophils are decreasing. So the recommendations from the BC Cancer Agency are to give the flu shot as close to their next chemo cycle as possible. So try to avoid giving them on the same day for that reason. And that is it. So basically, conclusion. So the pharmacist, the community pharmacist, really can play a key role in ensuring patients understand why they're using and how to use their G-CSF injections and how to properly administer them, and then give them a lot of information so that they feel kind of empowered when they're going home to do these injections, or their caregiver who's giving them for them. I think pharmacists can really support the patients through their journey by confidently guiding through that first administration of the G-CSF product. So even if you have them come in and they do the injection in front of you, that can really give them a lot of confidence. And then just being able to confidently answer those questions about administration and side effects can really help them. And just a note for the biosimilar products that are available in Canada, they're not interchangeable. They all come in a prefilled syringe in fixed doses, but really they generally really have very little differences between them besides the fact that they're not interchangeable. But a note, again, all of them do have a patient assistance program associated with them. So if a patient does have a copay and things like that, there are programs that are in place to kind of help cover the costs, because, you know, an injection of Lopelga can be like $1,500. So even if they have a 20% copay, it can be a little bit high.
So Megan, while we're on
Yes.
this slide, do you anticipate in the next coming years we'll arrive at a place where the biosimilars are treated more interchangeably once we have more confidence in switching?
I feel like that is the kind of the general consensus that I'm getting for at least some of the products in some areas, like these ones, like the G-CSF products. I'm hoping that that's kind of where we're headed, given that we're collecting more and more data to show that they are similar. So I would hope that that's happening, and it seems like that's the direction that we're kind of going in right now. Okay. I think for some products, like some other products, like in different patient populations, like in GI populations and things like that, I think sometimes some of the prescribers may be more hesitant to switch brands on the patient, and those patients might be more hesitant. But things like G-CSFs, I'm hoping that we'll definitely sooner rather than later kind of get enough data to kind of change those regulations, which would really be beneficial to the patients, I think, overall, and then make everyone's lives easier, because the physician usually just comes back and says, yeah, sure, that's fine.
Yeah, I agree. It would make it easier on the pharmacy side if that brand is missing, so that the pharmacist doesn't have to be chasing the prescriber.
Yeah, and chasing down these prescribers is pretty hard. So
Yeah, I know. Like everybody wants to focus on their patients. So if we can get rid of trivial things, it makes it easier for everyone. One more question, Megan. So in your experience, you obviously have very deep experience on this topic. I wonder if there are common prescribing errors or confusions or dispensing issues or even patient administration issues that you've encountered that we should be aware of.
yeah,
You've probably covered a lot in this session already, but anything else comes to mind?
that's a really good question. So there I haven't seen too many prescribing errors specifically coming from physicians. Most of the time, it's only if they write a handwritten script that's like missing the brand, and usually they honestly don't care what it is that you're giving them, as long as you're giving them the right product. I think in terms of administration or like patient administration or issues, I think the timing of it can be an issue. I think that's one of the biggest ones that comes up with the error of timing. And then sometimes, occasionally, like if a patient's not confident when they're administering their syringe, prefilled syringes, although it's pretty easy, they can inject like partial doses if they're not confident in what they're doing. So that can be an issue as well. And then you're not sure how much they've received. That issue is more kind of almost important when it's like with Lapelga or the Filgrastum products, because it's kind of a one-shot deal. So if they don't do it right, then they're not going to be protected for the full cycle, as opposed to the Filgrastum short-acting, where they'd have another chance to do it. So that's kind of one where I'd like to show them. I have you can get from the companies as well these pre-filled syringe like demo kits, and so those are pretty nice to show the patients, and then you can show them the syringes and like what it looks like after it's been depressed and everything. So I think having those available for the patients to play around with, it's really helpful as well, so they don't mess up their $1,500 injection.
That's really great advice, Megan. Let's move to the next slide and have some closing remarks here. Megan, it's been really great to have you for the last hour presenting on this topic. I think anyone who was with us for the live session or watches the recording after, I think will have really a lot more confidence engaging with patients on this topic. So I really appreciate you joining us and bringing all these learnings. I know that Megan would welcome questions after the presentation or any comments. And we might even have more sessions with Extend next year. So if there are any topics on oncology that you'd really like to learn more about, for sure send them to Whole Health or to Megan, and we'll definitely consider those. Do you have any closing remarks there, Megan?
I just want to say thank you for everyone who attended the session, and I just really hope that after being here, you feel more confident in counseling the patients on how to administer them and answering any of those questions that come up on the fly, that you kind of can pull them out of your back pocket and not have to waste a lot of time looking for the answers. So thanks again.
Great. And for folks to know, like, this is session number 3. So the first 2 sessions are posted on Whole Health's YouTube channel and on the Facebook for Whole Health. So this one will be joining them very shortly. So they'll live on if you want to refresh at a later point. Thanks again, Megan, and have a great night.
Thank you.